Good morning, Rachel. What seems to be the problem today?
Well, I have got the OSCEs coming up, and I'm just not really confident with formulating differential diagnoses from histories and examination.
Oh really? Is there anything in particular you are having trouble with?
Well, I guess I have not been great with patients who have presented with a headache.
That's okay. Tell me what you do know about headaches.
Okay, I'll give it a go. Headaches are observed as pain or discomfort between the orbits and occiput, arising from pain-sensitive structures. It is quite a common presenting complaint, with about 85% of the population experiencing some form of headache within a year.
Tell me more.
Well, things like migraines, tension and cluster headaches, and respiratory infections are quite common causes. Whilst I really would not want to miss a subarachnoid or intracranial hemorrhage, and look out for a space-occupying lesion, I'm just not really sure how to go about determining what is what.
That's okay. We will work through this together. Most of what you have told me is correct. We will work on developing your clinical reasoning. So firstly, let's think broadly about the causes of headache. The serious causes can be broken down into the following categories. Cardiovascular. For example, as you said earlier, subarachnoid or intracranial hemorrhage, temporal arteritis and so on. Severe infection. For example, meningitis, encephalitis or intracranial abscess. Neoplasia. And hematoma. You also probably would want to rule out glaucoma and benign intracranial hypertension.
Okay, that seems to make sense. But what questions should I ask to help determine what is wrong with the patient?
I'll give you some tips for obtaining information about the headaches. Firstly, it's important to have a system by which you ask questions. Many use Socrates or Neil Ducaf-Fayette. Diurnal pain patterns can be particularly important in headaches. You should also ask about associated symptoms such as nausea and vomiting, dizziness and weakness, light sensitivity, blurred vision, rhinorrhea, fever and swears, watering and redness of eyes. On top of that, you could ask about any recent trauma, current medications, or how stressed they are feeling.
Ah yes. I remember some of this now. And the red flags symptoms for headache are sudden onset, severe and debilitating pain, fever, vomiting, disturbed consciousness, worse on bending or coughing, worst in the morning, neurological symptoms and signs, young obese female, new headache in elderly. At least that's what I remember a resident telling me. Is that correct?
Yes, Rachel. That is pretty much correct. Those are some red flag symptoms. Since you brought that up, it's also important to consider red flag signs. Do you remember any?
I'll try. Red flag signs with headache are altered consciousness, altered cognition, meningism, abnormal vital signs BP, temp, respiratory rate, focal neurological signs pupils, fundi, eye movement, tender, poorly pulsatile cranial arteries.
Well done. You seem to know more than you though about headaches. When I think about how I'm going to approach a person with a headache, I think it is very important to take a careful history, develop a high index of suspicion, and use CT scanning judiciously. Other investigations are consider ordering RFBC and a lumbar puncture. Depending on the situation, you might want to look up the significance of those investigations in relation to headache at a later date.
That seems like a pretty good approach to me. I will definitely look at the significance of those investigations later as well.
I'm glad to hear that. Now, based on the approach to history I mentioned earlier, what are some ways you would distinguish a migraine from other differentials?
Well, migraines more often occur in females, and there is an increased incidence between the ages of 20 to 50. One of my tutors actually told me yesterday that a good mnemonic for remembering the symptoms of a migraine is pound. P for pulsating pain and photophobia. O for onset, which is 4 to 72 hours. U for unilateral pain. N for nausea and vomiting. D for disabling. I would ask the patient if they had any aura preceding the headache.
That is a good mnemonic, and you have managed to tell me most of the information. Is there any other common causes for headache which you could discuss? For example, tension headache.
I do not really know enough about tension headaches to feel confident. Could you please tell me about them?
Tension headaches, Rachel, have a couple of particular features. The pain is typically bilateral, lasts for hours, is mild to moderate in intensity, and can radiate to the trapezius or posterior neck.
Thanks a lot. That really helped.
No problem. Migraine and tension headaches are some more common causes, but you also want to make sure you don't miss serious causes. The two I usually look out for are subarachnoid hemorrhage and bacterial meningitis. Subarachnoid hemorrhage present with a sudden, excruciating headache, vomiting, rapid loss of consciousness and neck stiffness. Bacterial meningitis has a similar but different presentation. The classic triad is fever, headache, nuchal rigidity. You, the patient, may also have a rash, photophobia, nausea or vomiting. Does that sound okay?
Yes, it does. But I was wondering what you would see with someone who had a space-occupying lesion? Considering you mentioned neoplasia as a serious issue earlier.
Brain tumors can present in a number of different ways. A headache due to a brain tumor will often come on gradually, be worse on waking and improve throughout the day. Nausea and vomiting can be made worse by coughing or sudden head movements. As always, you look for other recognizable features associated with cancer. I'm afraid that's all I have got time for today. I wish you the best of luck in your OSCEs and don't hesitate to drop by again in future.
Thanks a lot, Doc. It was really helpful talking to you. I guess I better go get my head into the books, if I'm going to pass. Goodbye.